Hi everyone, today I like to discuss about the HOCM, that is the hypertrophic obstructive cardiomyopathy, and main cause of hypertrophic obstructive cardiomyopathy is autosomal dominant type of mutation, or inheritance that is causing the beta myosin heavy chain mutation, and due to that there is asymmetric proliferation. There is asymmetric proliferation of septum near the left ventricular outflow tract, so there will be left ventricular outflow obstruction. Due to that there will be if I see the picture of HOCM, it is very important that if I see the picture, this is the septum, this is the septum which is thickened, that is banana shaped septum, and this is the left ventricular outflow tract, this is the aorta, and this outflow tract is obstructed, so this is called the HOCM, and this is very much common in the young athletes, and that is a most common cause for sudden cardiac death in case of the young athlete, and these things young athlete things is very much specifically mentioned in the questions of HOCM. If that is present, that young athletes, that is generally most commonly that is age indicating HOCM. And there is some type of so the main thing is that there is hypertrophy of the septum, so that causing the obstruction of the left ventricular outflow tract, and that causing decrease in the cardiac output, and also that causing the dyspnea, because if we see the heart, this is the left ventricle and this is the left atrium, and when the outflow of the blood through the left ventricular outflow tract is obstructed because of anything, there will be more pressure is generated in the left ventricle because there is more blood, and that causing more increasing pressure in the left atrium, and that pressure goes backward and goes backward through the pulmonary veins, and that ultimately increasing pressure in the pulmonary venules alveoli, and there is more congestion, there is congestion in the alveoli, and that causing dyspnea, and the angina. The most common cause for angina is when there is more pressure is needed to eject the blood due to obstruction in the left ventricle, more obstruction in the left ventricular outflow tract, so there is more thickening of the left ventricular wall, so there is increasing more muscles, so there is much need for the ATPs, and so there is more oxygen demand, and that causing angina. And another thing is that is a syncope because of there is less amount of blood go to the brain, so that causing the syncopal attack, and I previously mentioned that it is the most common cause for ACD in case of young adults, and another thing is that another important part is the sign. That is JVP increase because when the left ventricle have much blood, left atrium also have so increased pressure, so there is bulging of the left side of the heart, and that pressure backwardly shifted to the lung, and that pressure is go to the pulmonary artery, and that causing the left ventricular failure, and when there is ultimately so left ventricular failure causing right ventricular failure, so there is when right ventricular failure that causing increasing in the JVP. So JVP, when there is a JVP, that indicating the pressure or any abnormality of the right side of the heart, it always indicating the right side of the heart. That is very much important. When there is JVP, that is right side of the heart, there is nothing about the left side. And there is the Burnham sign effect. Burnham sign effect is when there is bulging septum encroaches or go into the right ventricle, so that increasing the right ventricular pressure, so that is called the Burnham's sign effect. Burnham sign effect is very specific for the HOCM. Burnham sign effect is very specific to the HOCM. And there is the angina, why angina happen in case of the HOCM? One thing is there is more thickening of the muscle, so there is more oxygen demand, so if the oxygen demand is not made by that, so there is more pain, so that is one cause. And another cause is that if there is decrease in the amount of ATP, because why there is when there is decrease in the amount of ATP, so what thing happen? Angina, because there is thickening of muscle, so there is blood, so now it is very clear that why angina happen, because angina why happen, because there is left ventricular outflow tract obstruction, so left ventricle is much left ventricular wall is much thickened, so there is more muscle, so the blood supply, the coronary blood supply is not made fully because cardiac output is decreased, so that blood is go through the coronary artery, so that is also decreased. So in the muscle there is less blood, so when there is less blood there is less ATP production, and when there is less ATP production, we know that our nerve has a resting membrane potential that is maintained by, what is the resting membrane potential? Resting membrane potential is, listen very carefully, resting membrane potential is the potential present at the basal level without any excitement of the nerve or the muscle. there the negative charge are present in the inner side and the positive side present at the outer side, and a pump, that is sodium potassium ATPase pump, where the sodium 3 sodium is going out and 2 potassium is going in. Because sodium is going out and there is plenty of sodium in the outside of the nerve or the muscle, so there this is going against the concentration gradient, so there is needed a pump. That pump consumes ATP. If there is lack of ATP, that pump is not properly functioning, so there is more sodium is going inside the nerve of the muscle, and the more potassium is going out of the muscle, so the inner side is more positive, so that muscle of the nerve is become more excitable, so there is that causing arrhythmia, because there is more chances for more excitable nerve or muscle, so that causing arrhythmia, and that can cause certain cardiac death. So it is also happen in case of HOCM. Now the apex. Apex is generally double or the triple apex. If we palpate the heart over our precordium, we can palpate there is double or the triple apex. And what is the murmur? What type of murmur is felt in case of HOCM? That is ejection systolic murmur, because the outflow tract is obstructed, so there is ejection systolic murmur, and it is there is no radiation because of the thick septum that absorbs the sound, and pitch is low. And the murmur is felt. Murmur is heard at the left. Third or the fourth intercostal space. Now, this is a very important concept, that the SAM, that is systolic anterior movement of the mitral leaflet. Systolic anterior movement of the mitral leaflet. And why this happen? This is the septum which is thickened, and this is the mitral leaflet. When there is less amount of blood and the heart contracting with less amount of blood in the ventricles, that causing more that septum attracts more the leaflet towards itself, and that causing more constriction of the left ventricular outflow tract, so that causing increasing obstruction in case of the HOCM. So this is the concept, that systolic anterior movement is specifically seen in case of the HOCM, and this mentioning of that in the question of your professional exams or in case of NEET PG or INICET, that indicates that is a HOCM. So it is a clue in the question that systolic anterior movement of the mitral valve is present, and that causing the mitral regurgitation. And the factor affecting the obstruction, factor affecting which increasing the SM. Increasing of SM is happen when there is less amount of blood in the heart. So when there is increased contraction, there is increased SM, so that increases the obstruction. That one thing. So which drugs which are used in case of heart failure patients to increase the contraction or contractibility of the heart, that is digoxin, which is contraindicated in case of the HOCM. And another thing is that the vasodilators of the diuretics vasodilator like the NO, and the diuretics like Lasix or furosemide. So these things decreases the preload of the heart. When there is preload is reduced, when it is reduced, and the blood in the heart chamber is also reduced, and that increasing the systolic anterior movement of the mitral valve, and that causing increasing in the obstruction and increasing in the murmur. So there is decreased blood. In other type of cases, in other type of malfunctioning of the valves, there is when there is more blood, there is more murmur, but in case of HOCM, when there is less amount of blood, there is more murmur. More blood, there is less murmur. So this is opposite thing which is happening in case of HOCM, and another opposite things are happening in case of mitral valve prolapse. And what is the treatment? Main treatment to decreasing the treatment of choice is the beta blocker. If the patient have any type of contraindication from the beta blocker, if the patient have asthma or other, then we give non-DHP calcium channel blockers like that is diltiazem or verapamil. This is the example of non-DHP calcium channel blocker, and DHP calcium channel blockers are the like dipins like amlodipine, nifedipine, nimodipine. So these are the DHP type of calcium channel blocker that if one give DHP type of calcium channel blocker, that causing more tachycardia, so that is contraindicated in this type of cases. But amiodarone is very specific to decrease the sudden cardiac death. Amiodarone decreases the chances of arrhythmia, and the best treatment is implantable cardioverter defibrillator (ICD) implantation. And another thing is that the septal artery sclerosis. If we do septal artery sclerosis by injecting ethanol to the septum, that causing decreasing of the septum, and that can also causing decreasing in the HOCM. Now this picture is very important. We discussed this. This is a septum, which is a banana-shaped septum, increased thickened septum, and this is the histopathologic slide, and we see the that is myofiber disarray, and there is zigzag pattern of the fibers, cardiac fibers, and the more bluish color things due to the collagen in the Mason trichome stain. So the very important thing is that here we can see myofiber disarray. So massive myocardial hypertrophy, usually without ventricular dilatation, and asymmetric septal hypertrophy, it is an important part, and myofiber disarray. This is very much important thing. Haphazard disarray of bodies of myocyte, and this is present in case of this. So this is the important parts of the HOCM. I think you will like that. And another thing is that another important thing is that restrictive cardiomyopathy. What is restrictive cardiomyopathy? Restrictive cardiomyopathy is very simple. There is this is our pericardium and this is our myocardium. Yes, if that is the constrictive pericarditis, our constrictive pericarditis, this is our pericardium. Okay, so constrictive pericarditis, there is more tough and more thickened pericardium, so the heart cannot relax due to tough pericardium. That is constrictive pericarditis. And another thing is the restrictive cardiomyopathy, which we like to discuss. Restrictive cardiomyopathy, there is myocytes are more tough, so it cannot relax. So the JVP signs of the restrictive cardiomyopathy or the constrictive pericarditis is same, because there is heart cannot relax, so the JVP sign for both these things are same. But in case of restrictive cardiomyopathy, we can see that these are the myocytes, and that the restrictive cardiomyopathy are caused by generally two types, and this caused by due to the fibrosis, and another causes due to the infiltration of some due to amyloidosis or other things, so or hemochromatosis. If the deposition is inside the myocytes, that is the intramyocyte, and if that is between the myocyte, that is the intermyocyte. So these two types of infiltration happen in case of the restrictive cardiomyopathy. So the intracardiac amyloid, intramyocyte deposition or infiltration is happening in case of hemochromatosis. These happen in case of hemochromatosis. But in hemochromatosis, there is more likely we can see the DCMP than the RCMP, and it's happening in case of thalassemia patients due to more and more blood transfusion, so more iron deposition, and that causing hemochromatosis like dilated cardiomyopathy, and there is conduction defect of the heart, and that causing sudden cardiac death and or the heart failure, that due to the conduction defect of the heart. And another cause is that is the Fabry's disease. Fabry's disease due to alpha galactosidase deficiency. And another thing where there is intermyocyte deposition of the proteinaceous material, that is amyloidosis, and this seen in various type of amyloidosis, like the primary amyloidosis due to the light chain deposition. And another thing is that is a familiar amyloidosis, and another thing is that the senile cardiac amyloidosis, there is transthyretin deposition, transthyretin problem. So this is amyloidosis. And another thing is that is a fibrosis. In case of fibrosis mainly due to the radiation at the chest level, due to some type of malignancy of the neck or on other part, that also affect the heart. So that is the fibrosis. Another important part is that the systemic sclerosis, and another important thing is that the low flare endocarditis, there is basic proteins, and there is more eosinophils which infiltrates the heart, and that causing low flare endocarditis and fibrosis of the heart. So there is not very much thing about the restrictive cardiomyopathy, and the treatment of restrictive cardiomyopathy is treating the underlying disease which is present, and other is a symptomatic treatment. So in another which are present in case of the hypertrophic obstructive cardiomyopathy, that is discussed here. So I think it is okay for everyone. Good night, stay safe, and keep improving yourself.